We will start immediately with Jack Stone, Associate Professor, University of Bristol. Thank you, Jack. We are looking forward.
Thank you. Hi, everyone. So I'm going to give a presentation about modeling the impact of cuts to PEPFAR-funded pre-exposure prophylaxis for people who inject drugs. So I'll be using the acronym PrEP for pre-exposure prophylaxis. So PrEP has been shown to be very highly effective as a prevention intervention for HIV. So efficacy estimates from systematic reviews have shown 80% efficacy in women and 75% in men who have sex with men. But the evidence for people who inject drugs is a bit uncertain, more uncertain, because there's been only one randomized control trial, which showed an efficacy of just under 50% in Thailand. PrEP is actually recommended by both WHO and UNAIDS as part of a combination of HIV prevention for all key populations. So this includes people who inject drugs, but uptake has been quite low. And PEPFAR has, since 2016, accounted for over 90% of all global initiations onto PrEP. But this provision of PrEP is under threat. So in January this year, the US government issued a stop work order, which paused all foreign aid. There was a waiver that was issued that allowed, amongst other things, PrEP to be continued, but only among pregnant and breastfeeding women. All other PrEP services were put on pause until further notice, and we're still waiting for that notice. So PEPFAR is still currently operating under waiver conditions. So this means that PrEP among key populations has basically halted. So the aim of the study that I'm going to present is to estimate the impact globally of a funding pause for PrEP among people who inject drugs. And this is really an extension of work that was published earlier this month in The Lancet HIV, where we modeled the impact of these cuts to PrEP in sub-Saharan Africa for all populations. So I'll refer back to this just at the end to put some of the results for people who inject drugs into perspective. So what we did was to develop a static model to estimate the short-term impact of ceasing PEPFAR-funding PrEP. So for each country where PEPFAR was providing PrEP, we estimate first the coverage of PrEP, and that's the proportion of HIV-negative people who inject drugs who were receiving PrEP. We then estimate the number of primary infections that will result from removing PrEP for a year, and by that I mean the number of infections that would occur among those who would have otherwise been receiving PrEP. And then finally, to try and account for secondary transmissions that can result from that, we estimate the number of secondary infections that could occur over a 5-year period, but still resulting from a 1-year pause. So in terms of how we parameterize the model, firstly, we use PEPFAR monitoring and evaluation data. So this gave us numbers of all populations who had returned for a PrEP follow-up visit in the 3rd quarter of 2024. After that, the data just hasn't been available. And so we're assuming that these numbers relate to the number of people who would have been on PrEP in January 2025. We use estimates from systematic reviews to parameterize the country-level estimates of both the population size of people who inject drugs, but then also the prevalence and incidence of HIV. For countries without HIV incidence estimates, we use a pooled estimate from our systematic review for low and middle income countries, which was 3.2 per 100 person years, but with some uncertainty in that. And then for the efficacy of PrEP, we use the estimates from the Bangkok tenofovir study. So that's a 49% reduction in the risk of acquiring HIV, but with a wide range, so between 10 and 72% reductions. Okay, so what did the PEPFAR data tell us? So at the time, there were, across 51 countries, 815,000 people receiving PrEP. 91% of those people receiving PrEP were living in sub-Saharan Africa. 10,000 of those were pregnant and breastfeeding women. So that means 99% of people receiving PrEP were no longer eligible to receive it. A third of all the total provision of PrEP was for key population groups. So that's people who inject drugs, female sex workers, men who have sex with men, and transgender women. So this again was across 51 countries and a third of all PrEP provision. And then finally, you get to people who inject drugs, which was only 14,000 people across 23 countries, so not all of the countries where PrEP was being provided. And that only accounted for less than 2% of the total provision of PrEP and about 5% of the provision of PrEP among key populations. So this is just a map that shows where PEPFAR was providing PrEP for people who inject drugs. So the gray shows countries without PrEP. So you can see like the left-hand side of this figure with the Americas, there was no PrEP. So we can zoom in a little bit. So globally, 0.1% of HIV-negative people who inject drugs were receiving PrEP. But across the 23 countries where PEPFAR was providing PrEP, it was a bit higher, but still very, very low at 1.1%. So this figure now just shows the coverage in those individual 23 countries, ordered from the lowest coverage on the left to the highest coverage on the right. So immediately we can see that most of the countries fall on this left-hand side, less than 1%. There's 7 countries which are actually higher than 1%, and 3 in particular which are above 10%. But this is all reliant upon the population size estimates that we have for those countries. So take those estimates of coverage with a grain of salt. So I've now kept the same x-axis, so the countries are still now ordered in coverage, but now the bars are showing the increase as a proportion of the new HIV infections that would be resulted from removing PrEP for people who inject drugs. So across the countries, we estimate a 0.4% increase in the number of new HIV infections over a year, but the impact is higher in places with the highest coverage. So in places like Zambia and Uganda, where the coverage is estimated to be highest, we estimate a 7% increase in the number of new HIV infections. So what's that relate to? Well, we estimate that the removal of PEPFAR's provision would lead to 230 new HIV infections among people who inject drugs globally over 1 year. And most of these infections actually occur just in 4 countries: Nigeria, Uganda, Zambia, and Tanzania. So that was just the number of infections over a year. If we take into account the secondary transmissions, which is the blue boxes on this figure, we estimate 670 new HIV infections over a 5-year period. Now, to put this into a bit of perspective, so I've added now onto the right-hand side of this the results for sub-Saharan Africa for all different populations. And the first thing we notice is that actually most of the impact of removing PrEP for people who inject drugs is here in sub-Saharan Africa. The second thing to note is that the impact of removing PrEP among people who inject drugs is far less than other populations, in particular female sex workers and men who have sex with men. And this really just reflects that people who inject drugs are not getting the same level of PrEP as those populations. And then finally, overall, in sub-Saharan Africa, we estimated that there would be an additional 6,700 new HIV infections and 10,000 when we extrapolate out for 5 years, just from a 1-year funding cut. So the impact of removing PrEP for people who inject drugs is very small in the context of removing PrEP more generally in sub-Saharan Africa. But the reason of that is because of the very, very low coverage. So we heard on Wednesday from Kennedy that PEPFAR funding cuts for OAT and needle and syringe programs just in 9 countries would have much bigger impact. So that would lead to 3,500 additional HIV infections among people who inject drugs and 6,500 additional hepatitis C infections. But there's been much more modeling more generally outside of people who inject drugs, which have estimated that not only PEPFAR funding cuts, but other reductions in international aid could lead to between 4 and 10 million additional HIV infections by 2030. So all of this shows the detrimental impact that these funding cuts are having. So there's a need to identify alternative sources of funding so that we can offset these cuts and protect these interventions and the gains that have been made, and also to ensure that interventions are not vulnerable to political shifts and changing priorities of international donors. On PrEP in particular, it's crucial that funding is found not only to continue what was happening, but actually to scale up PrEP. And that's true for people who inject drugs, but also other key populations. And high incidence settings among people in check drugs really highlight the need for PrEP, and that's particularly true in places where incidence is high, even among those accessing services. So in Myanmar, Pakistan, and South Africa, we've estimated, using programmatic data, incidences far exceeding 5 per 100 person years. And just because Kennedy's in a room either side of here presenting this work, I thought I would just show that harm reduction interventions could actually be used to integrate PrEP and provide PrEP. And even though this is reaching people who are already accessing services with lower incidence, you can still get very high impact from that. So if coverage is high, above 50%, then providing PrEP through OAT and NSP could reduce incidence by a third. In other settings with lower coverage, adding PrEP as you scale up OAT and NSP greatly increases the benefit of scaling up those interventions. So finally, I'd just like to acknowledge all the co-authors and also the Wellcome Trust who funded the study. Thank you.